My name is Cadman Leggett, and I'm a fellow in gastroenterology at the Mayo Clinic in Rochester, Minnesota. The title of our study is The Metabolic Syndrome as a Risk Factor for Barrett's Esophagus, a population-based case control study to be published in an upcoming issue of the Mayo Clinic Proceedings. This work was done in collaboration with several other investigators, and I would like to take the opportunity to acknowledge their participation. Who's at risk of Barrett's esophagus? We know that Barrett's esophagus arises from chronic gastroesophageal reflux, and it's a premalignant condition that can lead to esophageal adenocarcinoma. Other risk factors include older age, male gender, Caucasian race, as well as alcohol and tobacco use. We're beginning to understand the role that obesity plays in the pathogenesis of Barrett's esophagus. Obesity, specifically central obesity, may lead to worsening gastroesophageal reflux, and it is thought that this is by means of increased intra-abdominal pressures leading to disruption of the lower esophageal sphincter and causing worsening reflux. Now, the risk of Barrett's esophagus can also be mediated by metabolic means, because central obesity is associated with visceral fat that is known to be metabolically active. Patients with the metabolic syndrome have a high prevalence of central obesity and visceral fat. So to this end, we were interested in seeing the association between the metabolic syndrome and Barrett's esophagus. More specifically, we wanted to determine if this association was independent of reflux symptoms. For this purpose, we identified patients with Barrett's esophagus and compared them to both a control group with reflux symptoms and a control group without reflux symptoms. The cases were identified from an established population cohort here at Olmsted County, Minnesota, and the controls were identified through a GI questionnaire that targeted reflux symptoms, both in terms of frequency and severity. So patients in the control group without reflux symptoms did not report any reflux symptoms at all, and patients in the control with reflux symptoms reported reflux symptoms at least once a week, and these were severe reflux symptoms. We matched these three groups by age, gender, and time of follow-up, and abstracted baseline characteristics as well as other risk factors for Barrett's esophagus. We also reviewed endoscopy reports to determine the presence or absence of Barrett's esophagus as well as esophagitis. We used a multivariate model to compare these groups and divided the metabolic syndrome into its individual components and adjusted for each of the individual components, and also looked at the metabolic syndrome as a composite diagnosis to determine the association with Barrett's esophagus. In total, there were 309 patients, 103 in each group, so 103 cases, 103 controls with reflux, and 103 controls without reflux. These groups were predominantly Caucasian individuals, predominantly overweight with comparable BMIs throughout all groups. Approximately 50% of patients met diagnostic criteria for the metabolic syndrome in each of the groups. And the only difference between the groups was basically in the use of PPIs, or proton pump inhibitors, that was greater in patients with Barrett's esophagus. When we adjusted for each of the individual components, we did not observe a association between each of the components and Barrett's esophagus. However, when we took the metabolic syndrome as a composite diagnosis, we found that patients with the metabolic syndrome are at a twofold increased risk of Barrett's esophagus. This, interesting enough, is independent of reflux symptoms because that association was there in both the group with and without reflux symptoms. So in summary, we performed a population-based case control study looking at the association of the metabolic syndrome and Barrett's esophagus. We found that patients with the metabolic syndrome are at twofold increased risk of Barrett's esophagus, and this association appears to be independent of reflux symptoms. Now, this suggests that the metabolic syndrome as a composite diagnosis can lead to Barrett's esophagus, perhaps through its metabolic derangements associated with this syndrome. Obesity is increasing in our population, and it's important to determine a cost-effective way of screening for Barrett's esophagus. Thank you for your attention.
We hope you benefited from this presentation based on the content of Mayo Clinic Proceedings. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you're interested in more information about Mayo Clinic Proceedings, visit our website at www.mayoclinicproceedings.org. There you will find additional videos on our YouTube channel, and you can follow us on Twitter. For more information on healthcare at Mayo Clinic, please visit www.mayoclinic.org. This video content is copyrighted by Mayo Foundation for Medical Education and Research.